Hello, everyone. My name is Anthony Brown. I'm an investor here at Acumen America. I'm a Goldman Sachs and Manatt Health Strategies alumnus who is deeply passionate about driving innovation throughout our healthcare system at all levels. It is an honor to kick off our event today. Thank you to everyone who joined us last week for a strong start to the first of our three-part series designed to help address the impact COVID-19 has had on low-income communities across the country. We encouraged the plans and states from last week to follow up with the companies that presented where there were clear areas of alignment. As Eamon mentioned last week, we're in trying times as a nation, as evidenced by the profound social unrest being displayed in the streets. The very fabric of how we want our society to be structured over the next 100 years is being tested. Our identity as a nation is at stake, and it will be up to leaders like you to help determine if we will hand down a country to the next generation more closely aligned with our founding ideals. If present trends persist, we risk becoming a nation that finds more joy in pointing out our differences versus solving the structural barriers that exist within impoverished communities. But if we lean into the moment and align more closely to our founding ideals, we have the opportunity to build a country that ensures equality is structurally delivered across every aspect of American life. Our healthcare system is transforming rapidly as we see the proliferation of value-based care arrangements across the system. As the nation aggressively moves away from traditional fee-for-service models, our failure to prioritize effective anti-poverty efforts has put enormous pressure on healthcare leaders whose work is closely being tied to outcomes. The social conditions that promulgate the need for extensive focus on the social determinants of health didn't start in healthcare, and it will not end in healthcare alone. However, it will be up to us to continue to address the systemic drivers of the outcomes we see every day in our respective lanes. Health starts in our homes, schools, workplaces, neighborhoods, and communities. We know that taking care of ourselves by eating well and staying active, not smoking, getting the recommended immunizations and screening tests, and seeing a doctor when we are sick all influence our health outcomes. However, the conditions in which we live explains in part why some Americans are healthier than others and why Americans more generally are not as healthy as they could be. The reality is that in the United States, it is inextricably connected to race. No matter what side of the political aisle you sit on, the fact is that the gains that we've made in our healthcare system around innovation don't matter if African Americans still experience illness and extremely high rates compared to other racial and ethnic groups. Work is needed in this space, and leadership is required for this nation to become the best version of itself around the topics of race, poverty, and health outcomes. Today, we have a fantastic lineup of experts and innovative companies addressing the social determinants of health in a best-in-breed manner. We thank them in advance for their excellent presentations and deep insights. My challenge to everyone today is to commit to taking that meeting. Follow up with that entrepreneur. A win from this event would be every participant ensuring there are open lines of communication moving forward. On behalf of Acumen America, the Center for Healthcare Strategies and Adaptation Health, we thank you for joining.
Hi, everyone, and thank you, Tony. Thank you all for participating in today's demo day for Medicaid innovation. This is the second in our series of virtual sessions that are aimed at bringing together key state Medicaid leadership, health plans, providers, and community partners alongside entrepreneurial tech companies who are working through leading edge emerging technology solutions that are really aimed at addressing some of the key gaps in care for Medicaid beneficiaries, particularly those that have been exacerbated by the COVID-19 pandemic. My name is Deborah Kozick, and I'll be moderating today's session, and I'm thrilled to be partnering with Adaptation Health and Acumen on this effort. I'm the Associate Director of Delivery System Reform with the Center for Healthcare Strategies, and we're, for those who are not familiar, a nonprofit health policy resource center based in New Jersey that works nationally with a focus on supporting Medicaid efforts to improve outcomes for the members they serve. So the issues we plan to discuss today are near and dear to the work that CHCS supports. In the virtual room, we are excited to have with us over 170 folks and climbing as folks are joining, with representation from state Medicaid leadership across over 25 states, including a number of health plan representatives, providers, key community partners, foundations and funders, and other important stakeholders that are part of the cross-sector partnerships that we've been exploring and that are so pivotal to the work that we're doing and talking about today. I'm also so delighted to have with me 3 expert panelists representing a range of perspectives with regard to social determinants of health and Medicaid. We have with us Liz Osius, Director at Manatt Health, who provides policy analysis and strategic advice to a wide array of clients, including federal and state governmental agencies. We also have Therese Wetterman, Director of Learning Network at Health Leads, who oversees efforts to enhance and streamline social service integration among providers and community-based organizations, and RJ Briscione, Senior Director of Social Determinants of Health Strategy and Execution at Aetna CVS, who can speak thoughtfully to the health plan perspective, and we're hoping will round out the discussion today. So before we dive in, just a couple of quick notes. Our panel will be followed by, as Tony said, 3 technology companies who will be presenting today: Healthify, Propel, and Unite Us, who were nominated through a selective application process. And each will have about 15 minutes to present on their solutions, followed by a couple of minutes for Q&A. So to keep this session as interactive as we can, we really encourage you all to submit questions through the Q&A function on Zoom, both to panelists as well as to the presenting companies, and time permitting, we'll be posing these questions, and we'll also have the presenters follow up on those questions after the event. So with that, in the interest of time, let's dive into the discussion. So just at baseline here, some quick notes just from my perspective, just to kick us off, that I think are likely familiar to a lot of the folks in the room here, but I think are helpful to frame our discussion. And those piggyback off what Tony said with regard to the national recognition of the importance of screening and addressing social determinants of health or health-related social needs, and that these are so pivotal to improving quality of care and reducing unnecessary medical utilization among Medicaid beneficiaries. I think we also have kind of established that Medicaid has a range of levers to really drive this work, and we'll talk a bit about some of those and how those are evolving given the COVID pandemic, including some of the policy levers and payment reform efforts going on. And I think lastly, we also recognize the acuity and the scale of the COVID-19 pandemic and how that's demonstrating that we need, and arguably have always needed, really seamless integration with healthcare and social services, especially for Medicaid beneficiaries who often have a range of care needs. So given all of this, I'm hoping that each of you can just speak briefly to kick us off, speak to the historical sort of pre-COVID, if we can think back to that time not so long ago, think about the opportunities and the challenges that you've seen directly in your work in addressing social determinants of health within Medicaid. And if you can comment too on some of the drivers of the efforts to integrate social services with healthcare efforts, I think that would be just a helpful foundation for us to build off of. So if we could start first with you, Liz, and then continue with RJ and Therese, that would be great.
Sure. Well, thank you. And I'm really pleased to be here with everyone who's joined the Zoom. So I know our time is brief. I will try to be brief. In terms of historic challenges and opportunities, I think this may sound a little obvious, but I think one of the biggest challenges here is that we are weaving together sectors that do not normally collaborate, right? They often have worked in silos. And they are really distinct sectors. There are different missions, different cultures in healthcare and social services. You know, there are different sort of key players, and there are different revenue sources, right? You have community-based organizations that tend to receive grant funding for the services that they provide. Payers in the healthcare world are paying sometimes, you know, often fee for service. And so there are just a lot of distinctions. I think in particular, it's really different when you think about mission to provide housing because somebody is housing insecure, sort of end of story. When you weave healthcare into the mix, you are often addressing housing insecurity with this sort of ultimate goal of impacting somebody's healthcare outcomes and healthcare costs. And you might think about targeting a subset of the population or providing a specific set of services where there's an evidence base to sort of obtain that return on investment. So just at a, sort of philosophical level, these are two different worlds, and it's hard. It's always hard to bring two separate worlds together. In terms of the opportunities, right, the reason that the healthcare world has sort of come to the forefront and gained momentum in looking to integrate social services into healthcare delivery, I would say is because value-based purchasing has created this, value-based payments have created this environment in which there is the permission for some flexible ways to innovate and to think about purchasing, some people say buying health instead of healthcare services. So finding cost-effective ways to improve somebody's health or lower healthcare costs. And so that has set up, Medicaid especially, obviously because Medicaid beneficiaries are low income and are most likely to face these types of barriers, to be a real driver in this integration of social services and healthcare. Just to say very quickly before I turn it over to the other panelists, a couple of drivers, particularly in Medicaid, of that integration. I would say we have seen most predominantly Medicaid agencies, state Medicaid agencies, really leveraging their contracts with managed care organizations. And most states are now running their programs, at least partially, if not fully, through managed care. They have, especially in the last 2 years or so, been embedding into their contractual requirements new levels of, for example, requiring plans to screen members for their social services and ask them questions about whether they're food insecure. And if they are, refer them to a community-based organization, right? That's outside of the typical provider network. Refer them somewhere that can address that concern. They are asking plans to embed community health workers into care teams for the first time. And then very briefly, just on the financing, for folks who are in the weeds on Medicaid financing, there are, methods to help finance this in lieu of services and value-added services, ways to pay dollars for these new not healthcare services that, payers are trying to pay for. I would say the bleeding edge of that, there are a couple of states that have used extra flexibility from the federal government through 1115 waivers to develop, fee schedules or very specific payments to these non-healthcare providers for the social services. So that's just a little bit of a taste, and I want to pause there so I can turn it over to others.
Great, thank you. Therese, did you want to jump here?
Sure. Can you hear me okay?
Sure, yep.
All right, well, thanks for having me. I'm really excited to be here as well. I'll speak to this question more from, the provider side and what we've seen at Health Leads with working with healthcare organizations and their community partners to implement, social health initiatives. So I think, as we know, in general, a lot of the efforts in this space have been mainly focused on identifying and addressing unmet social needs, which, which are helpful and necessary in alleviating the immediate needs of individuals. But what they kind of fail to do, and I think this has been kind of this underlying challenge, is that they're failing to address the root causes really driving these needs. And it's just, a lot of providers are getting caught up in this kind of cycle of just, never ending needs and not enough community resources to address them. And, we haven't been as focused on really developing population-based strategies and connecting those to policy changes that can more effectively get at the root causes. So I think, as we're thinking about opportunities post-COVID, I would hope that, we start keeping those things in mind. But even kind of within the scope of social need programs, providers have faced a lot of challenges establishing and sustaining these initiatives. And I think the particularly challenging areas are kind of, in the financing of them, the cross-sector partnerships and resource availability, and and also with clinical integration. So, on the financing side, it can be really costly for providers to run these programs, especially when this work isn't traditionally reimbursed. I think value-based payment has driven a lot of excitement and new thinking around this. But what we're finding is that a lot of our partners are being asked to show an ROI that's tied to a healthcare measure to make the case for these programs as like financially viable for the healthcare system. And this is not only incredibly difficult to do from like a measurement perspective, but it also kind of isn't really capturing the full value of these programs, and really kind of makes them much more healthcare centric. So as Elizabeth mentioned, we've also seen really big challenges with coordination across systems and sectors. And, a lot of this is kind of stemming from kind of healthcare dominating the table and sort of the medicalization of social needs, like that we generally refer to that as. So where, healthcare is kind of more driving the agenda and the definitions of success. And while other stakeholders, in the social sector, like they do really care about improving health outcomes, what we're finding is that it can be really hard to sustain their engagement if the tools are all being pulled towards reducing ED utilization, because this doesn't really align with what their funding is tied to, and and what they need to be reporting on for their funders. So, I think it's great that we're seeing more resources being allocated like within Medicaid to address, social needs and social determinants of health. We're seeing, new opportunities or requirements to do social needs screening, and also experimentation with flexible services. But I think, we kind of really need to also be thinking about what's the end goal of these programs or these opportunities, and how can we make them a little bit more, broader than just, mainly trying to reduce costs for the healthcare system, and how do we better support population health. I think on the clinical integration side, I'll just speak to that briefly. As more folks are screening, it's really important that the providers are also enabled to do something with that data. It really erodes trust in the community to just screen for an unmet social need and then do nothing. But reimbursement or funding to support the workforces that do that, like community health workers, are just not available to the extent that they need to be. So, there might be, opportunities to provide a community health worker for someone who's working with, the highest cost, highest need populations. But we know that the populations who have social needs goes much broader than that. And what providers have to do is, really stretch those dollars to try to, provide care more equitably to everybody they serve and really meet the needs. So I think, an opportunity could be really leaning into opportunities to support the value of community health workers and other workforces that are driving a lot of this work, but aren't necessarily getting recognized for their expertise and the valuable work that they're doing.
Great, thanks. RJ, please chime in.
Hey, thanks so much. Thanks for having me here first from Adaptation and Acumen. Glad to be part of this. I'll pick up a couple things from the last two first, but if you think back to, for me, coming from the Aetna side, and then moving into a role that looks at social determinants for all of CVS Health is very interesting. And it's mainly been driven by Medicaid so far. Also our D-SNP populations, and we're getting there on the rest of our populations as well. We have actually very different solutions for commercial members than we would for Medicaid or Medicare. So I'll leave those aside for now. But if you think about the pre-COVID world of this, and still to a certain extent, these same things are still issues. It's if we want to tackle this at scale, which is really a boil in the ocean problem, right? And we have a couple thoughts on how we can do that. But it is very costly for everybody, and up and down the system. It's costly for us to kind of engage full scale on really integrating with human services, integrating social determinants. We're taking some steps into that water now that I'll talk about. It's also enormously complex. I was talking to one of the folks who will be following us last week, and said, we were going through some stuff with our teams, and said, this isn't easy, and we're learning that too. So we have some pilots that I'll talk about. It was really from the Medicaid perspective. I will say that it can be, for the Medicaid directors and the state departments that are on this today. I think they know this, but coming from a guy who used to do business development for Medicaid, and my job was to win those state RFPs, there's enormous power in the RFP. If you say we've got to do something, we are going to go do it. And so you're starting to see those show up. That's frankly why we started looking at this at the beginning. And then we really moved to, I know there's they're concerned about the medicalization, right, of social determinants. I personally don't want us to be responsible for that exactly, but to get my bosses and to sign off on this, we do have to show some ROI for what will be some fairly large investments should we choose to do this at scale. And we're coming about that in interesting ways, in ways that I didn't think we were going to at first. And we're learning every day on where there's some ROI here. I would say, I do like the idea of buying health. I think that probably comes out of our friends in North Carolina, which have gone kind of full scale solution here. I think that's what we want to be in the business of. When you think about a combined company now that's 400,000 people, and everything that represents all of CVS and all of Aetna, we're here to be buying health. If it shows up on one side, it can be magnified on the other side. And so my job is to think about what those social determinants mean across that enterprise, including pharmacy and PBM and all sorts of fun things like that. A thought we do have some pilots with Unite Us, who is one of the selectees today in 4 states for Medicaid. We're early on in learnings of those. The thing we've learned the most so far that we're going to be building on is the ability to create the funnel into those referrals is more difficult than you might think. Although you might think it's difficult. So as you all probably know, Medicaid members aren't like lining up to talk to us or to talk to anybody really about their care, and so we're able to get them in through the care management programs. It's a little bit more difficult to explain what this is and how that can help them through other avenues that we really need to open up and explore. So opening up that funnel, I think, is key. But the most key thing out there is from our perspective and from being able to track and understand what's going on with the member is 2 things. One was touched on earlier, is so if you do the referral, and if you get that member referred, we have to know the CBO, the Human Services Organization has to know what happened to them, and what they're doing and how they're going about that journey. Like referring them to something is not nearly enough. But more so than that, and this can help, I think, everybody in the whole system, the getting to the rising social risk members, right? So we know who our medical risk members are. We do a pretty good job, for the most part, in care management, taking care of those members. And those are the members we're referring now to these services. What we need is to go, and this is what I'm banging the table on internally now, is to go upstream of those members, find where the rising social risk is. There's enough data on that now. And to really reach out in new and different ways to get those members. And then for us, it's going to understand the ROI on what would have happened had they gone into the medical system instead of getting one of those referrals. And then for the CBOs to be able to create some value there. I will say just one more kind of big picture thought is that The CBOs can't be left out of this. I've gone on record saying that at other conferences. So in this world, it would be my goal, and I think it's many of my colleagues' goals, to skip as much as we can. There's going to be some of it, to skip fee-for-service payment to these organizations. These organizations, if they're truly showing us, as an example, ROI, they should be able to gain and benefit from that. So we're probably a little far away from that right now, but to get to a value-based payment opportunity for community organizations and for non-medical referrals. I'll hold it there because I know we're short on time.
Thank you so much. And we could unpack these for days. I think these are all great points. I just want to close out with a real quick lightning round for the three of you. Given today's event and given what Tony noted with regard to the current environment, the disparities in care and more broadly, and all of the issues you've noted that are exacerbated by the COVID pandemic, what will each of you really be looking for from these technology firms to add value in the Medicaid space? If you could just say, what that core thing is, just to close out this panel, that'd be great. And we'll start with you again, Liz.
Sure. I think RJ touched on something that we've seen the most of, which is this proliferation of referral and coordination platforms. The idea of being able to connect the healthcare providers and the social service providers and allow for that coordination across those industries. I think that's the greatest technological thing that we have seen take hold, and we've seen health plans talk about their use of some of those platforms, particularly right now with COVID, because COVID has laid bare the impact of whether someone can access social services on their experience of healthcare. Just to say very quickly, whether folks can shelter at home and still get the food that they need and the medications that they need. The connection there, especially in the isolation and stay at home between the social services and the healthcare. And I think, a range of technologies can help to bridge that gap.
Great. Therese?
Yeah, I would actually say that, and what we're finding is that it's not so much the tech, but it's the relationships and trust behind the tech that really is what matters. And the tech can be supportive with relationship building if done right, but I think what we really, kind of given the current state of the world, what we really need to be focusing on is, how are we building relationships and working with those hard to reach populations and communities that have been impacted by systems of oppression. So, we in general, we don't really have strong connections in this space, virtual or not. And we haven't made like a great effort to really understand the needs and priorities of, of those populations. And I think we're really at a point where we need to prioritize, the experiences and preferences of communities of color, if we're really gonna, be able to be effective and sustain, these new models. So, and we're kind of seeing this come out more clearly now with COVID, that, as there's with the contact tracing and outreach, that there are really deep trust issues with community members around like who's collecting the data, how's that data going to be used, who's it going to be shared with, and we're really seeing a lot more people refusing to engage in these systems because they don't trust it. So, I think, what we're trying to do at Health Leads is really, kind of push the communities that we're working with to really, share power with the communities that they're working with, develop data sharing agreements and governance structures that, enable communities, particularly communities of color, to have influence over the new systems and give them confidence in participating, and really working with the providers and social service agencies to really build trust, trusting relationships and transparency, so that these systems are actually sustainable and folks want to engage in them.
Thank you. And RJ, last but not least.
Yeah, thanks. So a couple different things on there. Obviously, we have the pilots with Unite Us. That's the referral model. And the question was, I think, somewhat for digital for COVID. So we are seeing a few things on there, some that we're looking at testing. We're also in our Medicare population, we're testing with PAPA, which was originally set up to go to do social isolation, companionship kind of in the home. They flipped to an all digital model. There's a couple other, I won't name a ton of names, but in my role, I get a lot of inbounds, and there's some really interesting things going on around social isolation and that's digital that would be really helpful for COVID. So we're taking a look at a few of those, and I think that space is ripe for takeoff. And then, I'd be remiss if I didn't mention one from the communities of color angle are, this has nothing to do with the question, but I have to put the plug in, or it has a little to do with the question. The CVS is doing 1,000 testing sites around the country. Those have all been, we have spent an enormous amount of time and effort to get those into communities of color, especially where there's where people are contacting COVID at a much higher rate than the general population, where there's communities of color. And so to Therese's point, we're having a really difficult time with the engagement there just for the testing. So I would encourage any Medicaid states to push their folks. Obviously, we're building relationships, not building, but we have relationships with a lot of the different African American and minority doctors associations to push folks to that testing where it's free and the privacy concerns are made. And then I would say on the same side, there's some digital opportunities that are very specifically multicultural targeted, that are heavily for Medicaid, that I think are some really good opportunities out there now. We're taking a look at working with those so that we can kind of fully engage around the spectrum. It goes back to my original point, how do we get people in to these opportunities in the communities ahead of the medical? We need multiple solutions around that.
Great. Thank you all so much for these really wonderful and timely insights that I hope, they align closely with the work that we do and what we're hearing, and I hope resonate with the virtual group as well. So thank you.